Hi, good afternoon, everyone. Thanks for joining in on the first part of a CAQH Core Price Transparency webinar series. In this first installment, we'll be talking about the regulatory landscape and industry readiness for advanced EOB. So we'll kick things off with a CAQH Core overview, and then our presenter from WEDI will give us an overview of his organization as well as a policy briefing. Then we'll dive into the first CAQH Core focus group, followed by the WEDI No Surprises Act survey, which was recently released. Throughout all of this, we're going to be joined by our panel of experts who will be weighing in with their insights. And then, of course, we'll end things with a Q&A. Some reminders here: you can access the presentation slides from the handout section of the GoToWebinar menu on your right. You can also download the slides and recording on our website after the webinar. And of course, these slides and recording will be emailed to all of you in the next 1 to 2 business days. Questions can be submitted at any time using the questions panel on the GoToWebinar dashboard. So please reach out to us if you have any technical issues or if you would like to ask a question to our speakers. So I'd like to introduce our wonderful panel. We're joined by Beth Davis, Senior Manager, Payer Path Operations at Allscripts, Stanley Mackinson, who is a consultant at the Cooperative Exchange. Both Beth and Stanley are co-chairs of the WEDI No Surprises Act Task Group. We're also joined by Rob Tennant, the Vice President of Federal Affairs at WEDI, and of course our very own Aaron Weber, who's the Vice President of CAQH Core. With that being said, I will turn it over to Aaron.
Thanks, Daphne, and I want to say a special thank you to our speakers today. WEDI has been a great partner over the years, and we appreciate Rob, Beth, and Stanley sharing their knowledge with our own audience as well. I'm going to give a brief overview of CAQH Core for those in the audience that may be newer to our organization. We are a participant-led initiative, including providers, health plans, vendors, government entities, associations, standard-setting organizations that have come together to develop operating rules or business rules to create common expectations in how and when and what data is exchanged, particularly to support the administrative side of healthcare, but increasingly also thinking about that alignment between administrative and clinical activities. We are the National Operating Rule author as named by the Secretary of HHS, and several of our operating rule sets have been federally mandated. We see our role not only to convene the industry through our work groups to develop operating rules, but also to support the industry anytime there is need for standardization or uniformity and how a problem is solved. So we are constantly testing our operating rules, educating the industry on adoption, measuring the impact through our certification program, but also working on issues like price transparency, where it may not be operating rules are the solution that the industry pursues long term, but there is a need for education for our constituents and our participating organizations and others that we work with to think through what is the best way to address the challenge or the requirements as set forth, and how can we do that in a consistent, uniform way that ensures we are using our resources most effectively and not adding burden on the industry. On the next slide, I just want to highlight our more than 100 participating organizations that join our work groups and subgroups and really are having those detailed level conversations around what are the business challenges our industry is facing and how can we address them through operating rules or other uniform approaches. Our health plans represent about 75% of insured lives across the US, and you can see we have a wide range of stakeholders that are engaging with us on a regular basis. With that, I'm going to turn it right over to Rob, who is going to provide a policy update on the No Surprises Act, and in particular, some of the requirements that our sector of the industry has been focused on around the advanced explanation of benefits. So Rob, I'll turn it over to you.
Thank you, Erin. And let me also say, it's been wonderful working with CAQH core over many, many years, and we appreciate the opportunity to speak to you today. So if we go to the next slide, I want to just briefly let folks know a little bit about WEDI if you're not familiar with our organization. We were founded by then Secretary of Health and Human Services, Dr. Lewis Sullivan, under the first Bush administration, where he called into his office some of the leaders in healthcare and said, how can we make healthcare data exchange more electronic and less manual? How can we develop standards and create guardrails for privacy and security? And that led to 2 reports coming out of the Working Group for Electronic Data Interchange that became the foundation for the administrative simplification provisions of HIPAA. So we go back a long way. We were named in HIPAA as an advisor to the HHS Secretary. We have close relationships with CMS, with OCR and ONC. Both CMS and ONC serve on the WEDI board. Go to the next slide. And our main goal is really to bring folks together. So create consensus, bring the various stakeholder groups together. And we do a lot of our work through our work groups, sub-work groups, and task groups. And you can see here we have a multitude of groups, everything from payment models to claim status and attachments to privacy and security. But I wanted to highlight 2 in particular, our claims sub-work group and our No Surprises Act task group. And I'm really pleased to be joined on this webinar by our No Surprises Act task group, 2 of our 4 co-chairs and 2 of the 3 co-chairs of our claims sub-work group. So we'll talk about them a little bit more. If you're interested in learning more about our work groups, we've put a hyperlink here. You can go and learn more about them there. But if we go to the next slide, we wanted to talk about the No Surprises Act and make it absolutely clear that this is a very positive step forward in many ways for the healthcare industry. There had been work over many, many years in Congress trying to address what is known as surprise medical bills, when a patient unknowingly is treated by an an out-of-network provider and forced to pay the difference between their in-network rates and out-of-network rates. This can be catastrophic in many cases and can actually lead to bankruptcy. And so the idea was, can we address these surprise medical bills? It took a while, but finally the No Surprises Act was incorporated into the Consolidated Appropriations Act of 2021. And we put a hyperlink here in case you want some beach reading. But this was a very bipartisan bill, and it was signed into law in December of 2020. If we go to the next slide, we'll talk about the major parts of the law. And of course, no patient balance billing for emergency services, and advanced estimates of charges from any provider for uninsured self-pay patients and for commercially insured patients as well. And really, that's what we're going to focus on here today. We're going to be looking at the data exchange requirements included in the No Surprises Act. And in that advanced estimate of charges, they also created the convening provider concept, which was a very new idea in healthcare. And we'll talk about some of the work that we're doing in that and some of the results from our survey that we just closed. There are some other interesting provisions of the law, including provider directory update requirements. And it's interesting there because they recognize that there is a real challenge in the healthcare industry in regards to making sure that health plan provider directories are up to date and accurate. And it's one of those issues that they feel was part and parcel with the surprise billing aspect. So the idea was to put pressure on both health plans and providers to make sure that their directories were up to date. There's also requirements for health plan price comparison tools and continuity of care for network changes. So if we go to the next slide, there's been a few actions put out by HHS. In particular, in July 2021, they issued an interim final rule which restricts surprise billing for emergency care, inpatient and air ambulance services. Health plans are to determine out-of-network reimbursement based on in-network rates, and patient share based on regular copays and deductibles. They did issue a second interim final rule in September of 2021, and that got into a little bit more in terms of the good faith estimate of items or services for the uninsured. And we'll talk about that because, of course, for the insured individuals, the advanced explanation of benefits, we still are waiting on supporting regulations.
Hey, Rob, this is Stanley. Just wanted to point out that not only is the provider directory information being up to date critical to all of this, but as you noted, the eligibility information for any individual has to be up to date because the requirements are different if someone is uninsured or paying for themselves versus being insured. So it's critical for the providers to have accurate eligibility information on any individual when they are scheduling services or requesting a good faith estimate. I know that's something that CAQH Core is very interested in, the operating rules around eligibility, but this is another piece where the eligibility and other transactions are impacted by this.
No, great point, Stanley. And the fact that the provider is expected to conduct this eligibility verification at the beginning of the process is a big part of how they would develop their good faith estimate as well. So, and CMS has put out standard forms for patient notices and good faith estimates. And they've also issued a number of FAQs. We could probably spend the hour discussing the FAQs, but we do have a link here if you're interested. They have a pretty comprehensive No Surprises Act website, and they're continuing to update their FAQ section. So I would encourage you to have a look there every once in a while. Next slide, please. So what has been delayed? And keep in mind that there is some pressure coming from Capitol Hill on the administration to get things moving in terms of the data exchange requirements. But there is recognition that the industry, candidly, is not ready. There are no electronic standards for the GFE or the AEOB. There's no easy communication among providers regarding charges. Again, keep in mind that this is all new for both plans and providers. So CMS has issued enforcement discretion and a postponement of the requirements for the convening provider requirement for uninsured and self-pay patients until the end of the year. There's also no regulations yet on estimates from provider to health plan and health plan to patients. Again, we're all waiting for the industry to come up with some standards and standardized business processes. And if we go to the next slide, we can talk a little about what's happening today. For example, the Da Vinci project under the HL7, the Health Level 7 umbrella, has a very robust patient cost transparency effort for providers to submit GFEs to health plans and health plans to send advanced EOBs. X12 is also updating their predetermination standards. For those in the know, they have just recently submitted for consideration to the National Committee on Violent Health Statistics the latest set, the 80/20 version of the X12 administrative standards. And the Cooperative Exchange has issued a white paper talking about some opportunities for how to exchange information leveraging current standards. So there is a lot of work being done in these areas. I don't know, Beth or Stanley, if you wanted to comment on any of the three areas.
Well, Rob, I think CAQH Core also had a set of suggestions for either the AEOB or the good faith estimate. But there's a couple of things I want to point out. This is an interesting case where CMS is waiting for the industry to really come up with the solution before they go ahead and issue regulations. That's a credit to the agency, but it does place them in a difficult position because the law that Congress passed actually said all this was to be in place by January 1st, 2022. But to their credit, CMS said, hey, the industry is in no way, shape, or form ready to do this. So they're holding back on enforcing these requirements. I mean, that being said, this is an opportunity for the industry to really work together and say to CMS, we've taken some time, we've looked at the requirements, and here is our best suggestion for implementing these new standards. Because much like the HIPAA transactions, these are brand new standards that are going to take some time for the industry to develop, to program to, and to implement. So this is, again, an opportunity to respond to CMS's delay. And I think that's what we're all trying to work on with all of these implementation issues and challenges.
And if I could add to that, Stanley, thank you. This is Beth. We're not, I don't think anybody's saying that there is one single way to do anything. I think we're just taking advantage of the opportunity to use the expertise in our areas and look for ways to grow our offerings and our interoperability to deliver on this absolutely fantastic opportunity. We kind of liken this environment for what we're trying to do to an evolution, and that the one thing that we do want to accomplish together above all else is standardized kind of interoperable solutions. So what would be counterproductive would be for everybody to go off and develop their own solution that has a different look, a different feel, different way of interoperating, so that you end up with providers going to, and patients, less patients, but more providers and organizations go into all these different portals and sections and different set of instructions and a different set of things and a different output that makes it difficult for patients to compare from one to the other. That seems like an enormous headache. And the more we can agree on how to work together toward this end and agree on standard, it can be multiple standards even, but standards delivery, so that we come up with things that can be compared, the better. And we also want to think of it kind of ideally in kind of a phased or staged approach as well. I don't know how many of you remember back in the day when we first when our banks, when you first got ATM cards and debit cards, and you used to only be able to use that ATM card at the ATM machine right outside of your bank, and you could only do certain things. And then years later, we started to get the ability, oh, well, you can use your card as long as you're in this kind of network of ATMs. And then you can withdraw and deposit from those, or maybe just withdraw, not even deposit. And then it came where eventually you were able to go to any ATM really and get to your bank for all the major banks. And then we could do it on our phone, and then we could start using these cash apps to exchange information. We didn't start 30 years ago with cash apps. Those things grew over time, and as those interoperability solutions matured. So I think if we can see this the same way and not look at getting 0 to 60 on day one, but to grow and mature together to deliver a final solution and deliver value along the way.
Yeah, and I also want to add that unlike some of the HIPAA transactions that were put in place to automate existing processes, we've got new business processes here that we're really struggling to figure out how to set up. Never mind the data transmission, it's actually the data collection and the actual business process. And that's what both the WEDI Claims Work Group and the NSA Task Group are working on, looking at what is the business process to create all of these things. Once we have a better understanding of the business process and the obstacles and some of the solutions, we can then move to the actual standardization. For the first time, we've got patients involved, and I think for the first time, we've got a requirement for providers to exchange this financial information, which was never in place before.
Thank you both, and great information. And we've listed a few of what we believe are some of the implementation issues and challenges. It's by no means complete. It's just sort of a snapshot. But as both Beth and Stanley alluded to, it's the process. This is brand new. We have no idea how this is going to work in the real world of healthcare. And so things like, how is a health plan going to process AEOBs and get them to the patient in the format that the patient requires? And how is the communication between the convening provider and the co-providers going to take place? And what happens if somebody says, no, I'm not the convening provider, it's the person down the street? So it could be a question of nobody wanting to take the lead. And of course, if a patient is shopping around for services, the health plan could get multiple requests, multiple GFEs, which would result in multiple AEOBs. And then there's the big question about, should this be a requirement for every single service? As the law stands now, even if the patient doesn't request it, they will get a GFE or an AEOB. And we all know that it could be confusing to get something that has some financial information in the mail, even though it'll probably say in bold, this is not a bill. It is still going to be confusing and is going to result in a lot of phone calls to both providers and health plans. And of course, the issue of provider and payer burden, and how can the industry come up with solutions to mitigate the hassle factor associated with this. And then, of course, there's all kinds of questions around provider shopping and when the service is scheduled, changes in circumstances, which would maybe change the cost component. And so there's a lot of issues in this area.
Right. And by the way, Rob, this is just to throw a little clinker in. This is only for commercially insured patients. Basically, these do not apply to folks that have Medicare or Medicaid or other federal programs. So The other little clinker is that the provider will have to, again, make sure the eligibility is accurate, that they are dealing with a commercially insured patient, not a Medicare or Medicaid patient. So it's all services, but not for all patients. So the difficulties and the complications, just as you dig through this, get worse and worse.
Unless they request a good faith estimate as a self-pay.
Yeah, exactly, because they could have insurance, but they may be perhaps they have a high deductible health plan and they're looking to pay out of pocket. So yeah, there's a lot of nuances that will have to be addressed right at the outset for when that patient calls for the first time. And keep in mind, this is not just for established patients, but somebody could call a practice out of the blue, having never been there, and they would be required to be sent a GFE. So yeah, a lot of issues, as Stanley said. Next slide. So I wanted to maybe to, if they didn't mind, turn it over to Beth and Stanley to talk about our two groups that are looking specifically at the No Surprises Act.
Sure. Hey, Beth, let's split them up. You want to take the NSA task group, and then I'll take the sub-work group?
Sure.
Go right ahead.
Sure. So the NSA task group was formed a few months ago to specifically do some deep dives and work around all of this very complex legislation. So we have 4 co-chairs, and we meet about once a month, and a lot of times the co-chairs will meet. And there's good attendance, probably 30 to 50 people attend these. And so we talk about, how can we get to that next step? How can we work to identify things and challenges? And also, what can we do to kind of advance ourselves and the industry toward the goals of recognizing the regulation? And one of the things that we tackled, well, there's a number of things that we do, but one of the things that we tackled pretty early on was the concept of the convening provider, that as we worked through the challenges, that seemed to be one that kind of came up a whole lot, because, not only is it challenging to kind of identify who the convening provider is and who the co-providers are, and not to mention just exchanging that data, for which there's no standard in place for that. But that it's a new concept, and that that introduces its own set of challenges because people don't like change, right? So we did continually run into roadblocks with that, because it really, how that gets implemented will define whether there's a whole nother set of data exchange between providers, and what type of obligations that puts onto the co-provider. A lot of people said extra staff would be needed just to do that part, even if it is, even if things are automated, it would still require a lot of extra staff to launch those automation routines. So we did a survey. It's about a 10-digit, 10-question survey that we ask those types of questions, and that information has been published. We're working on a letter to HHS with our results, but we had about 250, between 250, 300 respondents. Many of them were small business, small provider groups, but we had a wide variety. And there was general consensus that it was difficult to very difficult. Some of the responses were in the very, very high. This is going to be super hard, 80, 90% in some cases. So we learned a lot. It kind of validated what we had already felt by looking through the details. And so look out for that letter. You can see the results. I think they're posted on the WEDI website. And anything you can think of that I might have missed, Rob or Stanley?
No. Again, Beth, I just want to emphasize that our purpose is to not only identify issues, but provide recommendations for solutions to the government.
Yeah, and before I turn it over to you, I'll just emphasize that WEDI's eyes at this time are focused primarily on the business process that rides on top, because it becomes difficult to figure out where you're going to hook your input points, where you're going to collect data, what system you're going to collect data in order to drive the data exchange pieces of it downstream, if you don't know who's going to be doing what and where those, and you don't get clarification on the requirements for those in terms of regulation or just best practices. So with that, I'll turn this part over to Stanley to talk about our claims subwork group.
Thank you, and I apologize for some of the background hum. Apparently, the neighborhood lawnmowers must sync their calendar with mine, because every time I have a meeting like this, they seem to be mowing the lawn. So I don't know how they do it, but they're good at it. In addition to the overall NSA task group, WEDI has a number of sub-work groups. Somebody asked what SWG stands for. It's a sub-work group. WEDI has a number of work groups that are focused on individual transactions, the business side of the transactions. And we recognized pretty early on in our group, the claims sub-work group, that the good faith estimate was very close to essentially a pre-bill. Talk about predetermination, but essentially it's a bill that is created, a set of charges that are created before the services that are delivered. It's an estimate, we understand, but still needs basically almost all of the information that that is on the claim. So we began working on what the business process would be like to create a good faith estimate. And besides a sort of a broad step-by-step approach, we also thought an excellent way to look at this would be to take a look at some use cases. And actually, that's what we've been doing right now. We've identified several different situations, and we're going through each of those situations step by step to see what the business process is, what are the inputs and the outputs to create a good faith estimate. And this will, of course, help inform the standards organizations what needs to be put together. So we have examples like a hip implant, or there's one that we worked on today, a pregnancy that might switch from a regular delivery to a C-section, and what are all the processes involved with that? What are all the different the convening provider and the co-providers? And we're taking these step by step, going through the details, identifying issues, things that we know and things that we don't know, things that have to be brought up to CMS, and things that we identify in some suggestions. One item that, for example, that we came across today is what happens when you cross plan years. You begin a process, sort of a longer term treatment process, maybe towards the end of one plan year, and you go to the next plan year, your good faith estimates now have to be all redone because you may be in a different health plan. You may, the coverage changes, the payments change, and even providers may update their charges. So what happens there, and how do you update the good faith estimate? Which good faith estimate really holds in that case? So there's lots of.
Can I add real quick, Stanley?
Sure.
In the other thing that's really coming up that will be of interest to those on this call is the sheer number of times that good faith estimate has to be updated. Especially on these complex things that are scheduled out a couple months. I mean, we've heard feedback that scheduling a surgery might take 3 days. And that's not even with the good faith estimate, and contacting all those and pulling all the codified services together. So what we're seeing is, in order to kind of be accurate to the degree that it needs to be accurate, that you're having to update anytime the status changes, update anytime a provider changes, update anytime the plan changes. There's just, and then that then you get into all the times where the course of treatment changes or expected procedures change. So, we're not talking about just one good faith estimate and then you're kind of done. It's like, it's a very iterative, high volume process. So I'll leave it there.
Right. So, we invite people to participate. If you are, certainly if you're WEDI members, the claim sub work group meets twice a month. The NSA task group meets twice a month. Hopefully we will provide good, solid information for CMS to help them make some decisions for their upcoming regulations or guidance. Let me turn it back to go to the next slide then.
Thanks, Stanley and Beth. We're going to do a quick audience poll because it would be great to get a good understanding of who we're speaking with today, where you are in the process of thinking about the No Surprises Act requirements. And then we'll talk a little bit more in the details. We have some quantitative findings, both from CORE and WEDI around industry readiness that we're looking forward to sharing with you. So we'll give the poll a minute or two, or a second or two probably, and then we can probably close it. As you guys can see, WEDI has done a lot of really great work in deep thinking about the various scenarios and challenges that could occur as organizations implement these processes, and what are some of the things we need to be thinking about to ensure that we're getting there. So poll results show the majority of you all are awaiting further guidance. Some are planning for implementation, and a quarter of you are actively implementing. So you are, in particular, the organizations that I know, Stanley, Rob, Beth, and CAQH are all interested in hearing from how you were thinking about addressing some of these workflow areas. And to that end, I want to share the next slide, which gives you a bit of a visual about what we've been talking about in terms of that good faith estimate and advanced EOB sample workflow. This gives you a kind of an overall vision of, based on today's regulation and guidance, how this workflow could work. I think there is some debate still around, in the insured scenario, who is going to be responsible for gathering all of the good faith estimates, whether it's that convening provider or the health plan. But generally, these are the steps that are occurring throughout the stage, from when the patient schedules a request to the health plan sending that advanced EOB to the member. And you'll see too, there's also the health plan sending a copy of the advanced EOB to the provider. That's not included in the regulation. However, we have heard from provider organizations that this is really critical to help them close the loop with their patients on what has been shared. So I am going to go through a series of slides now around the work that CAQH CORE has done to convene the industry around these issues, and then talk about some of our data, open it up for discussion with our panelists. And then Rob's going to go through some of the WEDI survey results that Beth and Stanley mentioned. So last fall, a CORE advisory group came together and published a guidance document around what are the potential connectivity protocols, messaging standards, and related data content that could support the provider to payer exchanges of good faith estimates. So a very specific part of that workflow I just shared. And we'll see in a few minutes as we get through some of our polling results what that means. But this issue brief is available on our website. In 2022, we talked with our board and other industry colleagues, and it's really too soon to develop operating rules or anything around these topics. So if we go to the next slide, CORE's approach is to convene a series of industry focus groups to get a pulse from our participating organizations in the industry on where we are in terms of readiness, and do that throughout the year with a focus on various topics. So we had our first focus group last month, and we had about 30 organizations on, with a good mix of stakeholder types. And we did a series of polling questions to understand how people were thinking about, in particular, implementing some of the good faith estimate and advanced EOB requirements. And on the next series of slides, I'll go through some of the polling findings and key insights. all of these focus groups are going to touch on the key topics we're touching on today: policy updates, industry progress, standards, gaps, and opportunities for the industry. Next slide. So the first question we asked was, what is your organization's anticipated timeline for implementing the delivery of GFEs from a provider perspective to self-pay patients under a single convening provider scenario, and then also looking to the plans to understand what is their timeline for implementing and supporting the delivery of advanced EOBs. You can see, and as Rob mentioned, the requirement for providers to deliver a GFE is already in effect. So we're seeing about 44% of providers saying they're going to be ready to support delivery of that GFE within this year time frame. The health plans, that is where there have been some delays from a regulatory perspective. So almost more than 3/4 of the health plans indicated they were still awaiting further industry guidance before they move into implementing any of these requirements. Next slide. And then we also asked about health plans and their plans to deliver that advanced EOB to providers. As I mentioned, this is an optional requirement and not included. We can see that there's limited commitment from the plans to implement this optional step in the process. That 2/3 are awaiting further guidance, and about 22% chose other, which may indicate they might not be planning for this implementing this step at all. Next slide. And then we asked about exchange formats, and these are the same exchange formats that we discussed in our issue brief from last fall, but trying to understand what organizations were planning for exchanging the provider to payer exchange of the good faith estimates. And you can see here that industry is largely considering use of the X12 837 predetermination claim and then the draft HL7 price transparency implementation guide, both of which our other speakers had mentioned. We then looked at the combinations of what people had submitted in the polling results, and again, the most common combination is that 837 with the Da Vinci implementation guide as well. So using FHIR and also using more traditional EDI. There is still a significant portion of the industry that is looking at using non-standardized formats such as web portals or other proprietary methods. And as Beth mentioned, that could really send us down a path where we have a number of different implementations and organizations are going to have to send things in a number of different ways, which is really going to add burden to the process. Next slide. So we are going to have another focus group later this year, probably 2 more later this year. And this is a good segue into Rob's data, but we're going to have a focus group specifically with providers and provider vendors to talk about that exchange of the good faith estimate in the provider to provider scenario. So you have the convening provider and then the other organizations that, or the other providers that need to submit information for that convening provider to aggregate a full good faith estimate. So we're going to talk through some of the challenges, where organizations are, and if you're interested in joining us, I would encourage you to email us at this number or at this email address. This is what happens when I'm trying to get through a lot of content at once. So I'm going to quickly maybe open it up to our speakers for 2 to 3 minutes to react to some of this data that I shared from our polling results, and then we'll move on for Rob to quickly walk us through the WEDI survey results. And what I think is really interesting, Rob has selected some of the survey results, particularly related to this convening provider portion of the workflow. And it's really interesting to hear what the industry is thinking in terms of their ability to implement those requirements. So Beth, Stanley, Rob, any thoughts on the findings from our focus group?
I'm happy to start. And what struck me is that so many health plans are awaiting regulations. I think that signals that this is all brand new, that there's no easy solution. But as Stanley alluded to earlier, it's a little bit of a chicken and egg, in that the government may be waiting on industry to provide them some direction, and at the same time, the industry is waiting for the government to come up with a standard or standardized process. So if we're all waiting for somebody else, it could be a long time before we see any definitive action.
Yeah, Rob, not surprised by the folks waiting for government guidance. I think we even see that in almost any move in the healthcare industry. The only concern that I saw was this idea of proprietary formats, which is just going to make things very difficult for providers or health plans if they're supporting their own proprietary format and not moving towards an industry agreed upon standard. We all know the difficulty of dealing with proprietary formats. So I hope that's only because nothing has been decided by the industry as to what the single format or one or two standard formats might be. So folks are saying, well, let me get ahead of the game and I'll just put together something in case I'm required to put this together before a standard is adopted.
Great. Thanks, Rob and Stanley. Rob, do you want to walk us through some of the WEDI survey findings, and then we can answer some of the questions that have come through the chat?
Sure, I'll run through the results pretty quickly. As Beth suggested earlier, we got a pretty healthy response. We got 274 from our survey that we conducted in May. The majority came from smaller providers or clinics, which I think is representative of the entire industry. 11.5 from the large, 8.5 from medium size. So a nice representation, and of course you can look at the full results by clicking on the hyperlink here. But if you go to the next slide, really what we were trying to do is understand the perception of providers today. And so we asked a series of questions, including how difficult will it be first to determine who should be the convening provider or facility, and almost 2/3 responded that this simple task was going to be either very difficult or difficult, with only 11.7% suggesting it would be easy or very easy. We also asked the difficulty related to identifying all the appropriate downstream co-providers and or facilities for the specific medical service, and you can see here almost 90% said that was going to be either very difficult or difficult, and around 5% suggesting it would be easy or very easy. We also asked, okay, once you've identified these co-providers and facilities, how difficult is it going to be to collect the GFEs from them? And over 90% suggested that would be very difficult or difficult. Only 1% suggested that would be easy or very easy. So just on the front end of the process, it's very clear that it's going to be extremely challenging for providers to get this convening concept into process. So if you go to the next slide, we asked then a few other questions. In particular, there's some very tight time frames for getting information first collected and then distributed to the patient. So we asked, how difficult would it be to get the co-provider information, the GFEs, within 1 business day? And of course, you can see here almost 92% said that it would be very difficult or difficult. For those in healthcare, you know, even the most basic information, it takes days or unfortunately weeks to move from place to place. So I think this is a prime example of just trying to identify who the co-providers should be, then reaching out to them and getting an answer. Meeting that one business day is next to impossible. And then once you have the GFEs, they must be provided to the patient within 3 business days. We asked how challenging that would be, and 89% said it would be difficult or very difficult, with just 2.6% suggesting it would be easy or very easy. And then if you go to the next slide, we did ask about, and again, CMS has floated this concept of putting the responsibility on the convening provider to determine the lowest cost option for the patient. So for example, would they be expected to identify ASC instead of an inpatient facility? How difficult or what's the level of support? Most, 63.4% were opposed or strongly opposed. 22% were somewhat or strongly supportive. And then the idea is, could a health plan be required to consolidate the GFEs from the providers and facilities? 80.7% were strongly, somewhat or strongly supportive, with only 11.5% opposed or strongly opposed. And that really leads us to the final question on the next slide, which is, do you support a delay in the convening provider facility requirement until there are standardized data exchange processes in place? And a very strong 83.1% indicated that they were somewhat or strongly in support of a delay, and only 7% were strongly or somewhat opposed. So we've taken these results and we've woven them into a letter that we are going to be sending to HHS probably next week. It will include not just the survey results, but also some recommendations on how to, in particular, as both Beth and Stanley suggested, phasing in some solutions if we don't have a standard in place for this data exchange requirement. So all letters and surveys are available in our No Surprises Act Resource Center. And with that, I believe we're going to open it up for discussion.
Yeah, thanks so much, Rob, and thanks for sharing that with us. We're going to do a quick polling question around topics that the audience is interested in learning more about in future education sessions from probably both WEDI and CAQH core. I'm going to note really the first question that comes in, you spoke to almost immediately, Rob, around given the absence of standards for the insured patients scenario, what is the industry discussion around delaying the requirements for January 1st? And it sounds like that may be one of the potential recommendations in WEDI's letter.
Absolutely.
Great, thanks, Rob. One thing I'm curious about, and we've gotten some questions about, is did you see any differences, or were you able to split the data to see, has there been any differences between the smaller provider clinics versus those in larger health systems? And what are the differences you're seeing there, and what lessons can be learned from that?
Well, I think not surprising. The smaller the organization, probably the less resources they have, the more concern they have about the time element. They don't have the staff dedicated for these actions. So I think you would see sort of a curve that would suggest a little bit more ability and support the larger the organization. But I think that applies to almost any change in healthcare.
I would agree with that.
Yeah, we did try and keep the survey anonymous, but I'd sure like to know who those 1.5% or so were that said this was going to be easy.
Yeah.
Along those lines, Stanley and Beth, I'm curious what your thinking is, within the number of topics to be addressed within the No Surprises Act and then specific to advanced EOB. What do you all see as the priority areas to tackle next?
Well, I really think we need to get a consensus on the convening provider piece, because that's going to drive, that's pretty high early in the process. And I need to think about that a little bit. We've got probably 15 things on our list.
Right. This discussion about does the health plan put it together or does the convening provider put it together, I think it's important for there to be a decision on. I'm not sure which way that's going to go, but I think the idea of considering what the right information that a health plan needs to create an AEOB is really critical. That to me is probably the biggest thing, that we're still not exactly sure what it's going to take for a health plan to compute and produce a valid AEOB that's beneficial to the patient. I think that's one area. Another area I'm still concerned about is actually the patient education. I have not seen much publicity around the No Surprises Act. There were one or two TV articles or a CNN or a Fox News or whatever your preferred choice of provider is. One or two articles, but there's not a whole lot of information. And as you go around from doc to doc or person to person, there are not very many people that know about this. And it's a little disconcerting that the industry is going to invest a lot of time and effort, and not that many people either know about it or are interested in it. I think we need to get that information out and make sure we understand what's beneficial for the patient. And
I would also like to see, a little spotlight on perhaps volume. There's a lot of potential here for having to do so many good faith estimates all the time, and then there's some complaints too already, people who are trying to implement it now, and they spend 3 hours on this and the patient just throws it in the trash can right in front of them. That was a legit piece of feedback that we got. And who really needs it? Can we narrow the scope a little bit until we get some real experience under our belts? Can we eliminate just doing these for everything and only do them on request, or certain types of complex services or things like that? So those are some things we're really hoping to see happen that will help us get a handle on exactly how it will be implemented and then scale up after that.
Great. Thanks to you both. And I think too, being able to measure the cost to implement and then the impact that the advanced EOB information is having on the industry and being whether or not it is being used to make care decisions will be really interesting to track. And I know the CAQH index is going to be looking at that in the next couple of years.
Right. And Erin, I know that you're focusing a lot on the AEOB, but I think we need to get some statistics on the good faith estimates that are now being created for self-pay or uninsured, and seeing if and how that process is working.
Absolutely. Well, thank you so much to our speakers. I'm going to turn it over to Daphne real quick to wrap up, and appreciate everyone joining us today.
Thanks, Erin. So quickly here, we have some upcoming education sessions and events. We hope you'll tune in to our upcoming collaboration with X12. We'll be talking about the eligibility and benefits, transaction standards, and associated operating rules. We'll also be presenting at the upcoming WEDI VPP Forum, as well as the WEDI Summer Forum. Finally here, I want to thank you all for joining us and our amazing panel of speakers for sharing all of their insights. Have a great afternoon, everyone. Thanks.
Thank you very much.
Thank you.
Thank you.